Thank you, Akshay. Thank you for having me on this course. It's been very nice to look at all the presentations that have been made until now, especially the videos. I thoroughly enjoyed Dr. Rashmin Gandhi's presentation. Am I clearly audible?
Yes, yes.
All right. So moving on to the last topic for this course, I'm going to talk to you about red flags in thyroid eye disease and invasive fungal sinusitis. I have no financial disclosures to make. You will see certain full face photographs of my patients for which we have the consents in place. So my objectives today are to take you through certain abnormal presentations in both thyroid eye disease as well as invasive fungal sinusitis, look at certain confusing scans. There's a lot that has been spoken on ptosis, and I'm going to touch on it as well a little bit. Certain ophthalmoplegias that you see, again, atypical scans in invasive fungal sinusitis, cutaneous fistulas, and finally summarize with the help of 10 interesting cases that I've tried to put up here. So the first one that Akshay wanted me to cover was thyroid eye disease, and you typically tend to associate eyelid retraction with thyroid eye disease and proptosis with thyroid eye disease. The retraction can either be the upper or the lower eyelid, and this is a patient, a series of photographs following treatment, which kind of shows you the natural history in a patient with thyroid eye disease where they develop the inflammatory component. You treat them with steroids and at times immunomodulators or decompression to see a reduction in the amount of periorbital inflammation. However, there are certain patients that may present differently. So let's take a look at this gentleman. He came with this left eye proptosis. He had an inferior scleral show on both the sides. And, it looks very much like a thyroid eye disease. He did not have any systemic thyroid dysfunction. His thyroid function tests were normal. But strangely, he had had multiple scans done previously. And every scan was reported as him having a left vascular malformation. So now with this background knowledge, when I was shown the scan, to my mind as well, these kind of shadows in the orbit looked very suspicious. This is not how the classic fat stranding in thyroid eye disease looks. So it sort of set me thinking that is this, it's in all the quadrants, it's intraconal, extraconal, ill-defined. Is this a form of lymphangioma which is restricted to, the posterior orbit and to the area just behind the eyeball? Even if you look at his muscle enlargement, it's not very classic of thyroid eye disease. So that set me thinking that, we need biopsy in this patient. And I thought in my mind that we do an open sclerotherapy where you enter the orbit, biopsy, as well as inject sclerosant into the vascular channels. That's what I did. However, histopathology only showed fibrofatty tissue. His entire collagen vascular profile and thyroid function tests were repeated, and they were again normal. And this is how he looked after the intervention that we performed with the residual proptosis. So I asked for another scan, and I saw these persistent orbital shadows there. And he was very bothered with the proptosis that he had and just did not want to have an eye that looked prominent like that. So considering that we could not figure out any sort of a lesion in the orbit, definitely not a malignant lesion, I thought that decompressing the orbit might not be a bad idea. Since we've definitely ruled out a malignancy, there's nothing that's going to go from the orbit outwards. And I performed a 4-wall orbital decompression for him, following which he remained stable with this kind of appearance for a period of 5 years after treatment and never had any issues related to any vascular malformation. So that is the first case which I wanted to show you. And if I can just take you back to the original pictures, the image that he came with had CT scan with contrast. And we do not typically advise, contrast enhanced CT scans for a patient with thyroid eye disease. So it got me thinking, could it be just the diffuse fat stranding that we label on a scan? Does it look like this when you inject the patient with contrast? That remains to be answered. However, we proved with all the surgical means that he did not have any other lesion in the orbit, and he was never treated with steroids, and these lesions remained persistent over the next 5 years. So moving on to another set of cases. So essentially, I put up this collage here just to tell you that you'll have all sorts of eyelid retraction in thyroid eye disease. It could be your upper as well as lower eyelid, or just a subtle lower eyelid retraction, or a prominent lower eyelid retraction as you see in these patients. But retraction is one of the hallmarks of thyroid eye disease. So what do you do when you see ptosis? This is a lady who has bilateral proptosis. You can see that from the worm's view here. But along with that has this ptosis. So do you investigate a patient like this, or what do you do? There are several situations in thyroid eye disease where you will see associated ptosis. This lady just had an aponeurotic ptosis and essentially was not really bothered. So we did not offer any sort of surgical correction. But just to tell you that you can see ptosis in thyroid eye disease. These are her scans. Whenever you see ptosis, it's important that you work up and you definitely build up a diagnosis of corroborative diagnosis of thyroid eye disease associated with ptosis. And you can see in the coronal cuts, the thickened medial and the inferior rectus muscles, and this nice tendon sparing muscle enlargement on the medial recti on both the sides, which is very classic of thyroid eye disease. Since she was not interested in any intervention, we left her alone. Now look at this, another lady who is a known case of thyroid eye disease with right minimal proptosis compared to the left eye on the worm's view. A little bit of probable lateral flaring on either side. It's not very classic, but yes, a little bit of proptosis and a deranged systemic thyroid profile. So this was her. She had certain ocular surface related symptoms which were taken care of. And then 3 months later, she comes with this picture. So now she's developed ptosis, and that's her concern. Why are both my eyes looking smaller? And this is not what you classically see in a thyroid eye disease patient. So what do you do in such patients? You image them is one that we already spoke about earlier. And second, a lot has been spoken about myasthenia. You perform an ICE test for these patients and you see an improvement following ICE test. You can run the entire panel of myasthenia workup on these patients. But just to drive home the point that 5% of your thyroid eye disease patients can have associated myasthenia gravis. So when you see ptosis, we've established two things. One, image and look at the orbit, look at the apex. Second, you do a myasthenia profile to rule out whether the patient has coexistent myasthenia gravis. Now, this is another lady who has an inflammatory thyroid eye disease, and she's being treated with steroids. And this is post 3 days of treatment with steroids. She also has ocular surface issues on the right side related to exposure keratopathy. So after steroids, you're seeing a very suboptimal sort of response. And actually, there's a buildup in ptosis. There's a worsening. There's lid edema here, but no ptosis. There's still lid edema here, but now ptosis. So it's not just the mechanical component that can explain ptosis. So in such patients, even though your vision might be maintained, look for color vision and image the orbit to figure out if there's compression at the apex. Thyroid eye disease with compressive optic neuropathy can also present with ptosis, and that's what she had. And even though she was in the active phase of the disease, you see these muscles sort of squishing the optic nerve right at the apex. Coronal cuts would have been better, but unfortunately I don't have those. So she underwent an orbital decompression of the inferior wall and the medial wall, as you see over here, to sort of relieve that compression from the optic nerve and displace the muscles towards the sinuses so that the optic nerve has a breather. So 3 things we've established in ptosis when it is associated with thyroid eye disease. One is your run-of-the-mill aponeurotic ptosis can be associated with thyroid eye disease. The second one is compression at the apex. And the third one is associated myasthenia gravis. Now let's move on to a little bit on invasive fungal sinusitis. We've had a lot of discussion on muca. I'm going to show you certain other interesting cases as well. This introductory slide is just to sort of make you understand that this is how your typical bacterial sinusitis would look. You'll have the rubodolor, color pallor, loss of function, all of that, along with a scan which may show you certain abscesses and an associated sinusitis. This is typically your bacterial sinusitis. Now compare that to this patient who has this large abscess in the eyelid and associated even intracranial abscesses and a complete loss of your lateral wall and bony destruction that you see all around. When you see this sort of bony destruction, it's more likely to be fungal sinusitis. This is a very recent patient who presented to us with just a little bit of limitation in adduction. But he, if you look at the history that I've noted down here, he is a COVID recovered patient. He's very young, 27 years old, was never diabetic earlier, but due to the severity of SARS-CoV-2 infection, he was treated with steroids. And in 3 weeks after treatment with steroids and complete recovery, he developed this sort of diplopia and restriction in adduction on the right side. So this patient had already undergone some amount of sinus debridement, and he had this orbital presentation here. The micro and histopathology from the sinus debridement, you see this black area here, which tells you that a large amount of sinuses have been removed, was suggestive of mucormycosis. So just to tell you that so much of orbital involvement in the inferomedial quadrant can present with an absolutely quiet eye and a little bit of nerve palsy and ptosis. So this is one of the red flags that we should all be aware of. Treatment wise, a lot has been spoken on mucor in a lot of courses at AIOS. I'm not going to get into the details, but essentially every patient gets systemic amphotericin B and sinus debridement, and a select patients require orbital interventions in form of debridement or transcutaneous retrobulbar amphotericin B or exenteration if the disease is severe. And then COVID positive or COVID negative status also sort of affects your decision paradigm. Now moving on to certain other cases. So this is a gentleman who complained of just a 2-day history of ear pain followed by this severe eyelid involvement in 2 days. Typically we know that fungal infections are indolent. They present after, they have a subacute course, but this is just a 2-day history. He is a known diabetic since 2 years, borderline control, no COVID history, and he presents with vision of PL positive and has a CRAO on fundus examination. And if you look at his clinical presentation and the scans, you realize that there is this necrosis of wide area of necrosis of the skin. This is abnormal. This is not common in bacterial fungal infections. And when you image him, you can see the ipsilateral side sinus is completely hazy. So this again is a pointer towards fungal infection of the orbit. And we performed his swabs, as well as he underwent an ENT procedure where he underwent FES is the wrong word, but he underwent an extensive debridement of the sinuses. And all of it, when subjected to histopathology and microbiology, came out as aspergillosis. And he was treated with amphotericin B and itraconazole for a long period of time. And this is him. You see that the lower eyelid abscess over a period of time has completely resolved with treatment. So this is one presentation. When you see a necrotic eyelid like that associated with orbital cellulitis picture, think fungal. One another lady here who complains of left sided, ocular surface symptoms, redness, watering, blurred vision since 15 days. She has an inability to close her eye, as you can see over here. She has had this abnormal appearance for over 10 years. And she now has the subcutaneous nodule, as you're able to see over here. So, so what do you do with her? Obviously, you need tissue diagnosis here, but before that, you'd go in for a scan. Now look at the bony orbit here. It is so abnormal. Look at the maxillary sinus, it's completely involved, and look at that thickening of the bony orbit. So it's not only bone destruction, but also hyperostosis, which can be a sign of fungal infections. We performed incisional biopsies from our nodules as well as from the bone, and it grew Aspergillus flavus. We could see it on the smear. It grew in culture, and the DNA was also positive on a PCR testing, which sort of leaves no no doubt as far as the diagnosis is concerned. So she again had aspergillosis. Surface symptoms were taken care of by a tarsorrhaphy. The nodules were debulked. You really can't do much about the bone, but she was treated with ketoconazole for a period of 4 months and radiologically was stable at the end of treatment with no further worsening. So bone destruction, bone hyperostosis, skin necrosis, all signs of fungal disease. A couple of last slides. This is another gentleman here who presents with left total ophthalmoplegia and has this kind of discharging fistula that you are seeing superomedially. Again, a known diabetic and has a long course of symptoms lasting for about a year and also has vision loss. So a cutaneous fistula with a cellulitis-like picture, again, is very suggestive of fungal infections. On imaging, he had this apical involvement, and look at that destruction of the bone superotemporally. So destruction and in the previous case, hyperostosis, both sort of point towards a fungal etiology. The last case here, this is pre-COVID era. If you look at the scans, they're 2002, who presents with total ophthalmoplegia, very minimal sinusitis, and you have this apical involvement, which in a known diabetic patient with deranged blood sugars. So in his case, again, to establish the diagnosis, we had to go in endonasal endoscopic and remove a bit of tissue from the orbital apex and subject it to microbiology and histopathology, both of which suggested fungal sinusitis. The reason I put this picture up is when you have apical involvement, you do not see sinusitis, do not start the patient right on steroids. It's important to get tissue diagnosis to rule out fungal infections, especially if you have host factors like diabetes and deranged blood sugars. So essentially, orbital fungal infections can masquerade inflammatory neoplastic vascular pathologies or nerve palsies, or it can look like your run-of-the-mill Tolosa hunt and have an apical presentation. But if you see an immunocompromised patient with ophthalmoplegia or subacute presentation that has bone destruction, hyperostosis, or these kind of cutaneous fistulas and skin necrosis that I showed you, suspect a fungal etiology and get a micro and histopath workup to back your diagnosis and treat the patient accordingly. Thank you so much. I hope I've finished on time.